healthcare providers, and the media. The first in 2007 to define the crisis that we were facing, and then in 2009 to outline for everyone the shape of the solution, which is to come in the form of a patient-centered medical home. Our goals, I think, are similar, if not identical, to about every other medical home project that anybody has ever seen. One is to certainly improve clinical outcomes, but simultaneously by improving those outcomes, controlling healthcare costs, reducing them if at all possible, along the way to improve the experience of both patients and providers, in turn leading to the enabling of retaining the physicians we have and recruiting those that we need. Covering as large a region as we do, the original concept included developing three pods, 3 sub-areas in which we could organize ourselves to engage the care coordinators, health educators, the pharmacists that we would need to work across practices to address the needs of our patients that simply have not been addressed in the conventional fragmented healthcare system, limiting the work of primary care to a 10-by-10 office setting. One of these pods is located in Plattsburgh to the north. In the middle is Adirondack Lake, organized around its local hospital, the Adirondack Health Center, and in our Lake George area, Hudson Headwaters Health Network became the focal organizing point for this kind of additional work going beyond the physician's office that represents the medical home. Consistent with New York statute, this was to be a 5-year demonstration starting in January 2010 with the earnest hope on the part of all that rather than sunsetting at the end of 2014, we would learn enough to morph and develop into a permanent reimbursement system, one that would define new reimbursement strategies and new care strategies well beyond the Adirondacks. The criteria were to develop a readiness assessment practice by practice. There are 33 separately organized practices within the pilot. For each to have a work plan to achieve at least level 2 recognition by NCQA as a patient-centered medical home by the end of 2010, which was later stretched to be the last day of this month, February 2011. By July of last year, the continued participation in the pilot was to include meeting NCQA standards for e-prescribing. That is, at least 80% of all prescriptions being e-prescribed in a territory where very few of those prescriptions had ever seen an electronic printer. As it turns out, in August we did a survey, and rather than 80%, pilot-wide we achieved 96.3% of all prescriptions being sent electronically within the entire service area. In year 3, we are hoping to reach the crossover point where the investment being made by the payers would be returned in the form of savings throughout the rest of the healthcare system. Terms of the pilot financing are that there be at least one evaluation and management visit and code within the previous 24 months of the start of the pilot, that we would reach beyond simply those who had had contact with the healthcare system to include household members if they could be identified, that existing reimbursement would continue, but added to it would be $7 per member per month to support the combination of new investment in care coordinating teams, increased physician compensation to bring us closer, if not all the way to the marketplace, and to develop the data sets and the data warehouses they would need to better manage care and understand what the opportunities for improvement were to be. The further expectation is in the out years, if indeed we achieve the savings we are attempting, there will be a morphing of that very $7 PMPM into some kind of a gain-sharing program so that all stakeholders would be in a win-win-win position. Pilot Data is focusing in accordance with NC Gray standards on 3 clinical conditions, 3 for adults that is, and 3 for kids. The adult conditions being hypertension, cardiovascular disease, and diabetes. For children, pediatric obesity, preventive measures, and asthma. Data for these conditions initially, but eventually for all of our activity, is to be generated from the EMRs of the providers and from the claims data of the payers, housed in 2 warehouses, organized through our RIO, our Regional Health Information Organization, and funded through a New York State bonding grant authority called HEAL 10. Pilot oversight and coordination is being conducted by a governance council with the Department of Health serving as the chair and the organizer, and in technical terms, the supervisor of the project, thereby assuring continued antitrust coverage. There were to be 8 providers at the table, including the State Medical Society, an equal number of payers representing each of the managed care and other insurance organizations, as well as a series of non-voting participants, including legal staff and consumers, public health, service organization, and experts, including representatives elsewhere in the healthcare field, for example, the pharmaceutical industry, for example, Donna Lichty. The pilot budget is not insignificant. The original planning grant, as I mentioned, was a small multi-year grant that then led to a project development grant by HRSA in the amount of $540,000. A $3 million award was made by the State Medical Society in conjunction with the State Health Department for developing the IT capacities, particularly within 3 pods. HEAL 10, the State Bonding Authority, allowed for the development and placement of electronic medical records where none had existed, and the remediation of those EMRs that had been already installed but were not high performing. These funds were in turn to be matched and are being matched by the providers who have thrown their full souls and resources into this project. In addition, the $7 PMPM is estimated to yield some $55 million in new reimbursement to the providers over the 5-year course of the project. Outcomes. We are hoping that this project will refresh primary care, that we will be younger and stronger and well-groomed, but we understand we will have the same DNA as Marcus Welby and our predecessors in previous generations. But we hope to look like the younger Carl Waldron rather than the older and fading generation that that we need to replace. And with this, we'll move to Dennis Weaver. Dennis?
John, thank you very much for your overview. And one of the things that I should say, thanks to everybody out there for participating in this. I do know that we've also got a number of our co-stakeholders out on the phone, and then we want to thank them for joining as well, too. Cindy and I are going to follow John's excellent overview with just some of the more specifics that you may be interested in. I'm going to focus in a couple of areas, how we've helped and what these pods are, as well as for those of you on the phone that have an interest in the technology, I'm going to talk a little bit about the technology piece. And then Cindy's going to move to the details of the pods, as well as how some of the local implementation in primary care has gone. So that's what we've got in the next couple of presentations. I think all of us, one of the things that brings us to this phone call is our understanding that patient-centered primary care is important. I think one of the other things that probably brings everybody to this phone call today is a basic understanding that healthcare is no longer an individual sport, but is becoming a team sport, and that the only way we're going to provide good quality healthcare across the country is in a team sport activity. As John outlined, one of the challenges that we faced was in essentially these communities, an area about the size of Massachusetts, but very rural with primary care in very small shops. It's difficult for them to provide team activities because you may need part of a pharmacist, part of a nurse, part of a social worker. And so one of the things that we had to think about was how do we make a team sport out of very small primary care shops. We came up with this concept called PODS. Essentially what it is a central service organization. I think one of the unique concepts that we have in our PODS is that we pay the doctors the $7 PM. It goes into their practices, and then their practices essentially both subcontract but are essentially owners of these service organizations that help them out. One of the things that we've done in these PODS, as you can see from this slide, is needless to say, when you're putting payment at $7 per patient per month, we needed to have an attribution methodology, we need to know who the patients are, and we need to coordinate payments, and that was one of the early activities of our Central Services Organization, or POD. We've also found, and I'll follow up here with very intensive data issues that we have implemented. And of course, there's the quality improvement activities with quality improvement nurses and plan, do, study, act cycles and continuous quality improvement. We help each of the practices perform those activities, again, out of this central service organization that is owned by the docs, but essentially goes out and helps each and every practice. As John highlighted, and Cindy is going to talk about in more detail, the other thing that the pilot does require is that each of these organizations has a PharmD, has a social worker, and has a nurse. Those are all in place at this point, as Cindy will outline for you, and she'll talk a little bit about some of the work that those staff are doing around care coordination, case management, and disease registry. Cindy also will talk to you about some of the transitions of care that are being provided by these pods. In this team sport activity, I think it's very important to understand essentially how to provide health care. A lot of primary care today, as you know, is a patient-physician visit, but how do you integrate these other players into the healthcare system? A lot of you probably have seen Dr. Gwandi's, Atul Gwandi's article recently in the New Yorker about hotspotters. We have a similar methodology here. I think that this team sport requires both population healthcare management as well as individualized primary care at the patient level. And the way we do it in ours is we talk about something we call red hats. And the idea is if we could put a theoretical red hat on certain patients as they walk through the healthcare system and figure out who those patients are that need intensive care management, that have chronic disease, that would be high utilizers of care, who potentially will reutilize inpatient services or ER services on a regular basis. If we could figure out in advance who those are and provide this healthcare for additional health care for them, that would be very powerful. That's one of the key components that we're working on. And as we identify or stratify the population to theoretically put these red hats on patients, the next thing we have to do, as John mentioned, was go out and find them at their homes outside of the healthcare facilities and work with them there. And in that, as you can see from this slide, it's not just the physician encounter or the provider encounter that's important. It's how do we leverage the pharmacist, the nurse, the social worker, as Cindy is going to describe to you, in the team-based care. And then once we do that, of course, we have to follow up and measure our results and then start the cycle over again. I think one of the reasons that I wanted to highlight this to the group here is this concept that we believe it's no longer an individual activity, but it takes team-based care, and Cindy's going to describe to you how some of our teams are working to deliver this type of health care. The other thing that it requires, and Cindy's going to talk a little bit as well at the detailed level, and John already highlighted to you, is measurement. As we've agreed here previously, John has told you that diabetes, hypertension, and heart disease were selected as the chronic conditions that we would focus in the adult population. As well, in the pediatric population, we've chosen childhood obesity, asthma, and prevention. The reason that diabetes and childhood obesity are highlighted here is those are critical conditions, and each individual practice specifically focuses on unique aspects of those chronic conditions to try and improve the care. We also measure access to care, and as has been previously represented, efficiency, or trying to improve the cost. One of the other dramatic things that I think we have done is in working together with a very collaborative group. It's not just the providers or the state. The health plans have been extraordinarily supportive of our work, have been active participants with us, and one of the key pieces of participation has been to agree on a common set of measures that we could measure performance across the entire pilot, both for access, for clinical quality, and for financial efficiency. And it's no small order to try and get 8 different health plans, as well as 6 hospitals and 33 provider organizations to agree on a common set of measures. But that's something that we've labored at, but have been successful, and I think will be one of the things that leads to our long-term success. Now for a slide about the technology. As you saw, there's been a significant technology investment here. For those of the folks that are IT on the phone, as John highlighted, when we started about 1.5 years ago, less than 40%, less than 40, a small number of practices had EMRs in their primary care practices. And of those, about 18 months ago, we went out and tried to figure out how many diabetics in the region we had. And of the 33 primary care practices, only 2 practices could produce essentially how many diabetics they had in their practice. That was 18 months ago. As John has already highlighted, we've gotten EMRs implemented in every primary care practice, and we're now, as the lines show, in the process of connecting those practices to a regional health information organization and putting a EMR data warehouse, as you can see in the slide, called the Quality Data Center in place. In addition to that, we've also connected 6 hospitals in the region. And for those of you that are technologically inclined, you will see on the next slide, we'll stay on this slide, Cindy, but on the next slide, for those of you that are technology inclined, you can see the 5 HL7 messages that we are sending from the hospitals, and you can see the content of the CCDs that we're sending from the primary care practices. So all of that data is going into HCSNE, our local regional health organization. It completes a common record, and by New York State policy, then when a patient gives consent, the primary care practice or the hospital can download that complete record that aggregates all of the information from the health care that's provided for those patients. In addition to that, as you can see from the slide, we then send the data over to a quality data warehouse where we're working on those common set of measures and working on a pilot performance. That data center will provide performance at the individual physician level, at the practice level, at the pod level, and at the regional level. Break. Another key part of this slide is another data warehouse that was previously mentioned. In collaboration with our 8 health plans and in collaboration with Medicare, in our meetings that we have had in Baltimore, Medicare has agreed that they will put their data as well. So 9 health plans have agreed to put their data into a payer data warehouse. The payer data warehouse includes all of the claims data, all being, medical, inpatient, surgical, pharmacy, demographic data, and pricing information. And so one of the key pieces that we have is a complete, robust, all-payer data warehouse by which we can not only look at pilot performance, but one of the other key pieces that I highlighted in that earlier slide was to try and figure out ways to put red hats on our patients to figure out who we want to provide the intensive therapy for. And so as a technology overview, and I'd be happy to answer questions later, but we have put EMRs in. We've used the grant dollars to create a robust information exchange. And finally, we have put business intelligence tools on top of that, including both a EMR data warehouse and an all-payer claims data warehouse We're not only using these technology tools for measurement from an overall standpoint, but we're working very intently on identifying them for predictive modeling and for patient identification to understand who those patients are that we should provide the intensive case management for. So with that, I'm going to stop and turn it over to Cindy and allow Cindy to talk in some more detail about essentially what we're doing at the ground level within each of the practices for our care management. Cindy?
Thanks. As Dennis and John said, I am the pod coordinator for the Lake George area. We have pod coordinators at the other two areas, Karen Ashline up in the Plattsburgh region and Mary Welch in Saranac Lake. And the pods are distinctly different, and so a lot of the activities that are occurring at the pod level, even though we end up in the same place, the way we get there is distinctly different. Since I know the Lake George pod the best, a lot of what I'm going to talk about today is related to Hudson Headwaters and the other two health centers involved in our pod, Newcomb and Long Lake Health Centers. But a lot of what we're doing at Hudson Headwaters is also being done in the other two areas. So what I'm going to talk to you a little bit about today are some of the initiatives and practices that we're doing to transform ourselves into a patient-centered medical home model of care. In particular, I'm going to talk very little about e-prescribing because Dr. Ruggies already touched base on that. I'm going to talk about population management. I'm going to spend a lot of time on transition care and a little bit on EMR templates, and then wrap up with quality measures and improvement. As Dr. Ruggies said, one of the things that we needed to do as part of our pilot's guidelines for participation was that by July of 2010, at least 80% of our new prescriptions had to be written through an electronic prescription writer that was also linked to patient-specific demographic and clinical data. He did mention that by July, we had actually had written over 104,000 scripts. And I believe my numbers were 99.4% of those scripts were done through the e-prescribing systems. As he said, what's significant about that is that several of the practices in the pilot, including Hudson Headwaters, had not even gone to e-prescribing until 2010. And while others had e-prescribing capability in their practices, they weren't really using it to the degree that they needed to meet those levels of adherence, nor were they using it to its full capacity, including using the safety alerts that might be available through the system or the efficiency alerts. All of the practices in the pilot have established systems and processes to identify patients with one or more of our important conditions. And we're conducting in various degrees pre-visit planning. We're identifying patients who would benefit from care management or disease management programs. And we're working with our IT to develop disease registries and other tools such as flow sheets to help us to care for our patients with these important conditions. As Dennis alluded to, these data warehouses are going to really have to intensify our efforts, but we didn't want to wait until those warehouses were up and fully operational. We really wanted to put things in place now so that we could start to transform the practices. At Hudson Headwaters, what we have done is we are using chronic condition flow sheets. We have worked with our EMR vendor to actually fine-tune our flow sheets to coincide with our evidence-based guidelines. Our flow sheets automatically pull in pertinent information regarding the patient's medication list. For example, if we have a patient who's a diabetic, it's going to tell us whether or not that patient is on any ACE or ARB therapy. And if we have a patient with coronary artery disease, it'll tell us whether or not that patient is currently being prescribed antithrombolytic therapy. It also captures information related to comorbidities, family history. It manages historical information. In particular, it manages different lab results for diabetics like hemoglobin A1Cs, their lipids, their urine for microalbumin, and it keeps track of, on a historical basis, their vital signs such as blood pressure, height, and BMI readings. In addition, what we asked our EMR vendor to do was to add information on the flow sheet about what the patient's target goals for self-managing their chronic condition were. And we were able to have them work with us to do that, because what we decided was that at the end of the visit, this flow sheet was going to be an important tool for the patient to know where they stood currently with their disease and where we wanted to work with them to achieve those goals. All of the pods have been working to develop similar types of self-management tools. They also have set up systems for establishing target goals and for making sure that the patients are a vital participant in working towards those goals, and for establishing care management systems. The practices have also worked to establish processes for reminding patients about scheduled appointments and identifying patients who may need to be contacted to come in for preventative care or possibly follow up for one of our chronic conditions. We also have set up systems to identify patients who have not been in for different preventative tests, such as pap smears, mammograms, and colonoscopies. At Hudson Headwaters, our EMR vendor has actually automated a lot of these functions for us. We can do automated phone call reminders to our patients about an upcoming appointment. We have automated tickler systems for both preventative care services as well as follow-up visits, and we can send out messages through our automated communicator to our patients. We also have a system in place that if a patient is a no-show for an appointment, we can send automated calls out to those patients, and if the patient wants to schedule a visit, they can press a button and be hooked up with a live operator who will either establish a visit with them or send an email through to their office, and they will call them the next day to set that up for them. For preventative service clinician reminders, all of us have, as I don't think Dennis mentioned this, but with all of these different practices, you can imagine that there were a variety of different EMRs that were being used throughout the pilot. I believe that there were at least 10 different EMR systems. Luckily for us, we have been able to work very well with our vendors to help set up templates in each of the systems related to age-appropriate screening tests, immunizations, risk assessments, and anticipatory guidance. And also, with many of them, we've actually set up templates related to our chronic conditions and related to some of the measurements that we want to be able to look at the end of the day. At Hudson Headwaters, we actually worked with our EMR vendor to set up some additional risk screenings. We set up a screening for depression because we do have some geriatric grant monies available, and we can get patients plugged into our mental health system here. We also have CAGE questionnaires for folks to determine whether or not there may be a potential for alcohol abuse. And we do have a screening tool for a smoking cessation program that we're working with the Medical Society of New York State to establish here at Hudson Headwaters. One nice feature about these types of questionnaires is they don't need to be done by a physician. One of the concepts of the medical home is the care team and empowering everybody to work at the highest level of their licensure. And we've developed these types of risk assessments to be accessible to all members of our care staff, including our care managers, our mid-level providers, our social workers, et cetera. As I mentioned, there are several different care management programs being implemented throughout the pilot. For example, 2 of the pods have hired a PharmD, and they've actually established criteria in which to refer the patient to the PharmD for medication therapy management. One of those criteria is that if they have a patient who has been prescribed 10 or more different drugs, they would be eligible to be referred for the PharmD to look at the management of those prescriptions, as well as patients who may be transitioning from an inpatient to an outpatient venue who have had significant changes to their medications. All 3 pods have hired care managers and social workers. And 2 of the 3 pods are using these resources for transition care programs. Here at Hudson Headwaters, we have a transition care program. It's actually based on Eric Coleman's transition care program and his 4 pillars for medication reconciliation between the inpatient and the outpatient stay, following up with the patient with an office visit with their primary provider within 7 to 10 days of discharge, making sure that the patient is aware of those red flag symptoms that they may need to call somebody about, and actually helping them to understand who it is that they call, and setting the patient up with a personal health record where they can document questions that they may want to make sure that they ask when they go to that follow-up visit. One of the differences in our model is that the Coleman model was really based on a hospital transition care model. and we've based ours more on the primary care side. One thing that has afforded us the ability to do this is that our providers still go to the hospital and round on our patients. If we were using hospitalists, as some of the pods do, they're having to look at a different type of system, although it is definitely a doable thing. When our providers are in the hospital, they actually have access to the patient's outpatient record because our EMR is web-based. So they can access the patient's health center record. They can look at information such as what their current medication list is before they came in, because as we've found, patients are not always the most reliable reporters of what medications they think they're on or when they're supposed to be taking them. They can also access information on their current problem list, any recent lab or other diagnostic testing they've had, as well as any encounter information where if they've been in to see their primary provider. The hospital provider also has access to the primary provider's schedule, which we have found is very helpful. They're actually making those follow-up visits for the patients and telling them before they discharge them, this is when you will be seeing your provider, and working with them to make sure that that time is the time that's going to work with the patient. Because one of the other things that we've found from previous transition care programs is, oftentimes would be made, and they wouldn't be appropriate times for the patients, whether it be for transportation reasons or other reasons that the patient may have. We feel that by having our providers involved in this both at the hospital and the outpatient level, there's a greater acceptance from the patient to participate in the program. As a matter of fact, we've seen so much participation in the program that we started off with a full-time transition care coach when we implemented the program, and due to the volume of patients that are meeting the criteria and accepting to participate in the program, we just had to hire another part-time position. Our coach contacts the patient within 24 to 48 hours of the discharge. They work with the patient to address those 4 pillars that I outlined. And typically the program runs over 3 to 4 contacts with the patient, all being done telephonically, both before the outpatient appointment to make sure that the patient knows when they're supposed to be going and doesn't have any barriers to getting there, as well as after the appointment to make sure that the patient understands what was discussed at that visit. In addition, on the initial call, the transition care coach works to reconcile the patient's medications from the medications that they're being discharged on versus the medications that they were taken before going into the hospital. And the transition care coach goes right into the patient's electronic medical record, and she notes any discrepancies in the record. So when the patient arrives for their outpatient visit, the primary care provider can pull this information up and already know where there may have been changes to his medication regime before the patient went in. In addition, what we've done in our EMR is we have embedded an order set specific to transition care, so the provider knows the patient is on transition care and can actually pull up any interactions that our transition care coach has had with the patient. And that includes any responses the patient may have regarding problems that they're having, barriers to care, or whether or not they're following the prescribed treatment plan that was laid out for them upon discharge. I'm going to move on a little bit to test tracking. As everybody knows, test tracking and referral tracking are some of the big things related to being a medical home. All of our practices have put systems in place for tracking tests and referrals. In addition, at Hudson Headwaters, we have a patient portal, and we are using our patient portal to actually push the test results out onto the portal so that the patient can review them and have the copy of those to bring with them to appointments with other providers outside of our network who we may have referred them to. Our hope is a couple of things. One, increased participation on the part of the patient. Also, hopefully decreased excessive lab work, because I think one thing that we've seen happen over time is when a patient leaves our auspices and goes to specialty care, if lab work has been completed, it's important that they know it's been done so we don't see a redundancy in lab work being ordered. And lastly, I'm just going to touch a little bit on measures for performance. As Dennis alluded to, when you try to get so many people that are involved in this pilot together and establish a set of goals for measuring whether or not we're either adhering to our evidence-based guidelines or even more importantly, as to whether or not we're really making a difference and improving the quality of care for our patients, improving their ability to self-manage their care and improving their satisfaction with their care, as well as reducing overall healthcare costs. We've struggled a bit, but I have to say that on many aspects, in particular on the clinical quality aspect, we've come to agreement on what we want to measure. And we're really sticking with national standards in many cases, whether they be NCQA or HEDIS-related standards of care. Our hope is that with the development of these databases, we'll be able to report our measures at multiple levels, lowest level being at the individual specific patient level, and then all the way up through our provider health centers, networks, the pod, and the pilot levels. So with that, I'm going to conclude. I'm going to let John do a real quick summary and wrap up of all three of our discussions, and then I believe we're going to open it up to questions.
I'm back again like Freddie on Elm Street. Hopefully it's clear the Adirondack Medical Home Pilot is a work in progress. We've regarded 2010 to have been a year of tool building, installing EMRs, organizing care teams, developing new workflows. 2011, we're just starting as a time for focusing those new energies and applying new standards to the care of our patients. Next year, cross our fingers, will be the year of turnaround and the beginning of a payback on the investment that has been made by both public and private payers. I like to think of this as just-in-time transformation. New York State, like every other state it seems, is facing enormous budget crunches. In this state, Medicaid is anticipating a $5.6 billion cut in order to make the state budget work. There is no way in 1 year that we can transform the healthcare system, but the only hope for a sustainable, high-functioning system, we think, is application of a model that is the medical home. Without a robust primary care base, every intuition would say that there can be no good outcomes. Intuition is not enough. We need evidence, and up to now, what we've been relying upon is the evidence of the true leaders, organizations like Geisinger and Group Health, which do have data solid enough for us to base not only our hopes but our futures upon. We think that our special role in terms of public policy is to be able to demonstrate this model will work in an ordinary slice of Americana. Included in this pilot are not simply mature, high-functioning practices already with enormous electronic capabilities, but a spread of practices that are struggling in something close to a crisis environment to sustain themselves. What we know is all it's taken has been remarkable leadership by state government, the engagement of Medicaid and the Civil Service Commission in ways that are truly extraordinary, and also the very active and supportive participation of our payers. Not easy when there are, count them, 9 payers at the table, all trying to standardize and to find our way to the future. But we are hopeful and would love to come back in a couple of years and tell you about all our achievements. In the meantime, the best we can do, I guess, is take questions. So I think this is back to Jim to help us organize that part of the program.
Yes, and thank you all. And before we get into questions, Donna will be doing that. I do want to give out email addresses for people on the phone who would like to ask questions by email after this webinar. Dr. Rugge's email, have your pencils ready, is jrugge, J-R-U-G-G-E, at hhhn.org. So jrugge at hhhn.org. Dr. Weaver is dennis.weavermd, and that's W-E-A-V-E-R-M-D. So dennis.weavermd at eastpointhealth.com. Dennis.weavermd at eastpointhealth.com. And lastly, Cindy Nasivera Cordes, her email is cnasivera, C-N-A-S-S-I-V-E-R-A, at hhhn.org. So again, cnasivera, C-N-A-S-S-I-V-E-R-A, at hhh.org. Donna, you are our moderator for the question and answer. Your turn.
Donna, are you connected? This is Amy. I'm not hearing you, Donna.
Okay, well then I will jump in. And Donna, just jump in if you want. The question starting from the top, what patient satisfaction or patient-defined outcome measures are you measuring, if any?
Hi, this is Cindy Cordes. We actually have a contract with DSS to do a CHAP survey based on NCQA, patient-centered medical home. We're getting ready to do the baseline survey in the next month, and then we'll be doing repeat surveys throughout the pilot.
Another question from the same asker. How are patients and consumer advocates included in the design and governance of this model?
Thinking about this one. I guess this in part goes back to the community base of our primary care, the activities of the New York State Association of Counties in pulling together our communities through our summit meetings. I have to confess that at the governance level, we do not have any official consumer representatives, but these are meetings that are fluid and open to those coming forward. What we have been able to do, as we've organized the Adirondack Health Institute, is develop a leadership council that includes a variety of stakeholders, and they will include organizations such as the American Cancer Society, the American Diabetes Association, as well as professional societies, members of the pharmaceutical industry and others, is another way of keeping us providers on track.
Can you hear me now?
Donna, okay, you're fire away.
Lots of questions, and I have no idea what happened before, but I was trying to pull together some ideas here around some of the questions that are being asked. So while I was doing that, if these questions were asked, just let me know. But Dr. Ruggie, there were some questions around how patients and consumers and advocacy groups were brought into the fold. Was that asked yet?
Yes.
It was, and I stumbled through something of an answer. Yes. Let's move on to the next question.
Okay. Okay. Now, there are a number of questions around EMRs and the types of EMRs being used, and I think Cindy noted that at one point there were many levels of activity that will be able to be seen both at an individual provider level as well as the full program level. Are you starting to collect that data, and what are the inherent difficulties in using multiple EMRs?
Where do we begin? It's kind of, I guess, the answer to that. Yes, we've got 10 different EMR vendors that are involved in this process. Initially, and I guess I'll comment on kind of our technology challenges and how we have handled them maybe in phases. The first thing that we decided to do, we had about 40% of the primary care practices with EMRs, but as I suggested earlier, there was only one or two of those practices that actually were probably doing anything close to what is today called meaningful use. And so the first step of our process was essentially remediation of previous EMR deployments to help organizations more effectively use their EMR. And for those 60% of providers that didn't have an EMR, it was an initial implementation. Again, we focused on the e-prescribing piece of it, but for those of you that have installed or deployed EMRs, to understand that 60% of this pilot within 6 months not only deployed an EMR, but had e-prescribing up and functioning at a 99% level was a fairly dramatic implementation. And we owe some compliments to a number of the partners that we had, both the Massachusetts eHealth Collaborative, the work that we did in East Point Health, as well as our colleagues at HCSNE, which is the Regional Health Information Organization. So the first phase of the EMR challenges was essentially to get people using them and using them in a productive way. As Cindy highlighted in her comments then, one of the things that we very much focused on was ensuring that we installed evidence-based guidelines and that everybody was providing a level of consistent care across the chronic disease entities that we had. And so that was probably phase 2. We're now working into phase 3. And at this point, as those folks on the phone probably know, and it sounds like the questioner asked, most EMRs do not have good business intelligence tools in them to help you understand how to do things like disease registries and how to do population health management. The way we're doing it is, like I said in that slide, we are now connecting each of those EMRs in a standard format to a regional health information exchange and then pulling that data into a data warehouse where we will be able to provide both disease registry functions but measurement functions as well too. I will say one of the challenges for those folks that are on the phone, and I know we've got a number of technology folks on the phone, I suspect other folks are challenged with the same thing that we are, and that is as we start to create interoperability into our health information exchange, we're finding that vendors are at different stages in being able to provide that capability, and probably one of our larger setbacks at this point is getting interoperability established with these EMRs. So that is one of our huge challenges, and we're working both within the other projects in the state of New York as well as potentially joining some projects from other states to work with those vendors on interoperability. So that's probably the second phase of challenges. I think we've probably highlighted the third phase of challenge already. I think we're fairly proud of the fact that we found a common set of measures to measure, but needless to say, I think for those of you that are working on these kind of projects, when you start to think about a all-payer database, the data use agreements, the legal documents, the business associates agreements, and both patient confidentiality and HIPAA challenges should not be underestimated. And we have spent a lot of time and effort in those, but I think we've come to a conclusion that has made everybody satisfied, and we're in the early stages of getting those agreements finalized. I think there's light at the end of the tunnel, and I think we're in the process then of starting to move some of that data. So maybe in summary, we've dealt with the technology issues at all levels, at the local EMR implementation level, at the interoperability level, and at the business intelligence as well as sharing information level. And so those have been all unique opportunities that we've been presented with and tried to handle.
Thanks, Dennis. A couple of questions for Cindy that I think are very relevant and really talk to really the clinical model that you're working in. And I've had some questions here that are related, so I'll ask them for you to kind of maybe think through these with the group in total. They're centered around things like the tools that you're using. You mentioned we couldn't wait to have some things developed, so we've developed some of our own. What are the gaps in those kinds of tools, and what else are you looking for that might be useful? That's the first part of it. And the second part of the question is really around the types of conditions that you're looking at, not the specific conditions, but you mentioned things like you have pharmacists and social workers. One of the questions is really around mental health and substance abuse, since that might also be an issue in that particular area.
Well, you're absolutely right that mental health and substance abuse play a key factor, especially when you look at patients that are hospitalized and readmitted. We've found that a significant number of patients that are going back into the hospital actually have a mental health or substance abuse component to their disease. And right now, we don't have all the answers. We're kind of, as Dr. Ruggie and Dr. Weaver have said, in 2011, we're trying to establish what are the criteria for referring people to different services. But that being said, I can tell you a little bit about what Hudson Headwaters are doing because of the fact that we are an FQHC and because of the fact that we offer other services here than primary care, we're kind of in a unique position. We actually have behavioral health services here at Hudson Headwaters. We have both nurse practitioner Ps who can prescribe medications, and we have a lot of social workers. We do also have a couple of different grant programs, one for, in particular, the geriatric population and one for adolescents. And one of the things that we do is we actually try to do a depression screen on any of our patients that come in that are over the age of 65. And as I said, we've embedded that screen right into the EMR so that it can be documented. And depending upon the score that the patient has on that, that assessment tool, the provider can review that with them and make a determination right then and there whether or not they may benefit from one of our behavioral health services. So that's one of the ways that we tackle that issue. As for the measurement, you know, one of the things that's been the bane of our existence, but probably one of the more positive things, is that we were one of those practices that were not on an EMR when this all started. So when we went out and searched for an EMR vendor, we chose a vendor that we felt would not only work with us in the implementation of the EMR, but really work with us in transforming our practice to a patient-centered medical home. So in doing that, as I mentioned, we were able to get, I think, these flow sheets that met our chronic conditions, but we also were able to set up some quality reporting functionality that was very specific to those outcome goals that we had designed in the pilot project. So that's one of the things where, you know, we can go in at any time and say, okay, well, how many diabetic patients does Dr. Ruggie have? And of those diabetic patients, how many of them have a hemoglobin A1C greater than 9, or how many of them haven't had a hemoglobin A1C in the past year, as well as looking at those folks that we're doing really well with that have those levels that are either less than 8 or less than 7. The challenges, the biggest challenges that we've had to date are making sure that the way the system is programmed does accurately assign that patient to the proper primary provider in the system, as well as much as possible, making it transparent so that there are behind-the-scenes functionality that automatically populate those quality reporting measures. For example, I don't want to have to go out and data mine my lab data to find those hemoglobin levels. I want, when that lab comes in, either through an interface or an electronic fax, for that information to automatically go into that reporting capability. We're there, I'd say, with about 75% of the measures, but there's certain ones that we're still working through.
Thank you, Cindy. This is a question for Dr. Ruggie around the medical home neighborhood and understanding how specialists have become involved in your program. And the question relates to how they're involved, affected, or threatened.
Yeah, this is a question I love to answer. For the last 3 years, we've been devoting all of our medical staff meetings and lots of internal communications to try to get our primary care providers to engage in understanding and with the program. And really it was with the turn of the calendar this year, having done the EMR, having our new teams realize that most of the savings we're trying to achieve are as much in the hands of our specialists as they are directly ordered by us. And what we have done is engaged and brought into Hudson Headwaters a physician now most of the way through a preventive medicine program, but came to that program as a cardiac surgeon who developed a small physical disability that didn't allow him to do microsurgery on coronaries. And he is now our ambassador and liaison to specialty practices. So we have a Hudson Headwaters physician as part of our primary care group going specialist to specialist to say, we want you to know in detail what Hudson Headwaters is doing by way of providing medical home services, and know that our success depends on your application of evidence-based guidelines and practice that we generate together. Let's develop a consensus about what we should be doing, and then on a go-forward basis, we'll be looking at all of our work together to know what we can do together to make that care clinically effective and also cost effective. We've, at this point, contacted our key specialty groups, surgical groups, medical subspecialties. Everybody at this point is very eager to talk to Dr. Delco, and we expect this to bear a lot of fruit.
Thank you. Dennis, this is a question for you, and I think this is something that a lot of people are concerned about, and it's around data and the movement of data between what would ordinarily sometimes be competitors or between patients, physicians, and their health plans. And the question really is around cooperation and how easy or difficult might that have been to convince all of these organizations to begin to work all together for a common purpose.
Let me comment on that, Donna, and actually let me comment on that in two ways. John just previously answered the question about specialists and you know, how the medical neighborhood has been involved. I don't think John talked about it in the particular pod that he's involved in. I guess I'd like to add comments, and it relates to your question here, Donna, as well, too. I don't think we can say enough about the cooperation of the hospital partners in the communities. One of the key focuses has been highlighted here is that 2011 now is going to very seriously focus on essentially saving the $7 per member per month, or as you saw, that's aggregated to a total of $55 million across 5 years. And so one of the key pieces that in partnership with the local hospitals that we have worked on are what are the preventable inpatient admissions, what are the preventable ER visits, and what are the preventable readmissions from hospitals. And the hospital partners have been just extremely cooperative in the project, understanding that the healthcare system of the future needs to address these concerns and these issues. And so as you asked the medical neighborhood question, we've had tremendous cooperation, and I can comment that in these communities, the hospitals, specialty providers, and primary care docs sit in meetings very specifically focused on not just the revenue that's come in and the team-based care, but how do we specifically look at saving the money that's being invested by both the public and the private payers. Which draws to the second question that you asked then, is the only way that this can be done is by sharing information. One of the key mantras that we've led with is that you're sharing information, and the way we have set up our information systems is that we do have the ability to go in, but the data is shared for quality improvement reasons. We have created very unique user credentials such that the majority of the users across the system, in fact, there's really no user that can get in and essentially evaluate the financial performance of another organization other than the organization that they exist in. So one of the key design features that we've set up is that the data is shared for quality improvement, and that, but the financial data is only at an aggregated level to define performance. But that nobody, we've really worked hard so that nobody can go in and pull a data file down and impute the final financial performance or the market share of another organization. Now, that said, we do at the governance level, as was presented, have the ability for the governance leadership to see the financial performance of the pilot. And the other thing that we do have is the ability for each individual organization to see their financial performance. And when I see each individual organization, that includes not only the provider organizations, but we've set up the payer data warehouse such that each of the health plans can go in and see their own individual financial performance and see it as it's benchmarked against other organizations as well. So again, that's a little bit of how we've been successful at setting up the information sharing, is that it's based on quality improvement. There is no ability to impute any other organization's market share or financial performance. And then the third piece is yet done it in such a way that we can determine overall both quality, access, and financial performance. John wants to add a couple of additional comments.
a couple of governors ago in New York, the governor said that a crisis is a terrible thing to waste. I think fair to say we're not wasting this one. Primary care was brought to such a dangerous level that I think both our hospitalists and our specialists have come to understand that there's no way going forward that we in this healthcare system can protect current levels of volume. But the only way to protect margin or even assure viability is to choose new kinds of efficiencies. So we're really not going after the hospital, not going after the specialist. We have to go after the best care. And there will be a role, and a necessary one, for all of us who are providers in the system. For payers, it's much the same. For the payers, I think we're faced with the prospect of having no network of providers to offer services. And that's absolutely not viable and is a risk to the entire financing system when there is no provider system. To date, there's been, I think, extraordinary generosity of them to one another, and except when it comes to sharing very proprietary data about their own clients in the existing year, there's been amazing willingness to adopt common standards of care, use the similar standards of measures and all the rest, which goes against the notion of competition in the healthcare marketplace and how to establish advantage vis-a-vis one another. How this goes, we don't know. I think we have to live it out, but it is the dynamic that we're all caught in and need to work through together. And so far in this pilot, so far so good.
Well, that was put by both of you very eloquently. Obviously, this isn't an easy situation, but you made it sound that you have pulled the right people together and they're all walking towards the same objective. A couple questions around patients. Let me see if we can get a few of you to answer these. One of the things that came up was the request to know how many persons that are in the program right now, patients that are in the program, have the access to and are using the portal.
Yeah, we can only answer this for some headwaters, but we're the first client of our EMR vendor to adopt their patient portal as of June of 2010. We've made an enormous effort to reach our patients, to understand, have them to understand the advantage. This includes mailing to 50,000 people. This includes a postcard size instructions in every exam room to enter our patients. And so anybody who has in their family a computer, we've been urging that they sign in. It takes about 5 minutes. In the month of December, we had 6,000 hits of our patients utilizing the portal to come and reach us. And we have now we have just under 10,000 patients who have signed onto the portal, and with our universe being 60,000 users in any individual year, 70,000 over a 2-year period. We think in 6 months that's an extraordinary penetration, especially given the fact that probably 20% of our people have either never heard of a computer or don't know how to obtain one. And again, I think that anecdotally this is going to be catching on, and that patients love getting their information directly and in advance of their office visits, and we've shown we can do it. Yes, here's the word from Cindy.
Cindy?
One of the new initiatives that we are doing in our care management program is we're doing a light touch to all of our patients who are scheduled for an upcoming visit with one of our chronic conditions. And one of the questions that we're asking them now is, do you have an email address and do you know about our patient portal? Because our patient portal isn't just for communication. Our portal also has a whole component related to tools for education related to chronic conditions and self-management support systems. We have a lot of videos out there for the patient. So we're really trying to promote the portal as a tool for our case management and our patients with these conditions.
Cindy, as a follow-up question to that, there is some recognition that people do not necessarily understand how patients are dedicated to a particular provider. Someone actually said Are they married by you to the provider, or is this their personal physician, and how is that determined?
Actually, that was one of the first things that we had to do as a pilot. So this isn't just unique to Hudson Headwaters. This is, throughout the whole, every practice in the pilot had to figure out how were we going to marry a patient and a particular provider or care team. And we've all come up with different ways that we're doing that. From a Hudson Headwaters standpoint, it's part of our intake process. When, if a new patient comes into the system, we're explaining to them about the medical home. We're explaining to them about the role of that primary care provider and the care team, and we're asking them, who is your primary care provider? If it's somebody who had already established with us, we actually started this back almost a year ago. We had a specific place put into our practice management system, and we were asking our patients, who's your primary care provider, and we were documenting that on our system, and then we were validating that each time a patient came in for a visit. Similar things are in place throughout the pilot in varying degrees.
Thanks. And as a follow-up to the care that's given at the pod level, what are the ratios of physicians to patients, PharmDs to the pods, or how many PharmDs do you have in a pod? I know that you mentioned earlier that you had to increase the level of support around care transitions, but give us a sense about the other workers in those pods.
You may.
Well, again, it's very different depending upon the pod. Because of the uniqueness in each one of those areas. For example, when you're up in the Champlain Valley region, you're talking the majority of folks are either employed by the hospital in one of their centers or an independent practice. And in those centers, they actually are using the pod to deliver a lot of those care management components. I know that up in Champlain Valley, they have a PharmD, they have a social worker, they have at least one care manager up there. And I think right now, because we don't really know the true number of patients who are going to need those services, it's going to be evolving over time. Same thing down in Saranac Lake. They have a PharmD on board, they have a social worker on board, and I'm not sure if they've hired their care manager yet. Here at Hudson Headwaters for our pod, we have a transition care coach, a full-time one and a part-time one. We also have 2 RNs who do care management. We have 2 support staff for our care management program. We have 2 certified diabetic educators. One's a nurse, one's a registered dietitian. We have incorporated the use of 2 volunteers from our community health centers of New York. They're called Chicanis, and we're able to get volunteers from them to do a lot of patient outreach. And we are working also on the PharmD side, maybe a little bit differently than some of the other pods. We're looking at collaborations within our community because, we're really trying to make the medical home more than just Hudson Headwaters. We're really trying to make this a collaborative project throughout our area, and we've been working with a lot of the pharmacists at our different pharmacies because they have medication therapy management programs in place already.
Thank you.
Donna, I was going to emphasize that point that Cindy just made. One of the things that's hard to really calculate ratios because each of the pods, one of the early activities that we did was we went out and looked at what are the available community resources to do this work. And so when I say that it's a team-based sport, not only is it a team-based inside the huddle that goes on in a primary care practice and then the team that becomes the primary care practice in the pod, but essentially the pods have worked very hard at the community resources that are available in each of their communities. And it's interesting, frankly, in some cases surprising, that all of these programs are going on, but a lot of one program doesn't know about the other program. And so one of the key pieces that actually has been somewhat of a success is somewhat creating a community infrastructure, for lack of a better term, to combine programs together and get some leverage out of this. And so it's kind of a tough question to ask, and I think if we would just say what's the ratio of what's been hired, we're clearly underestimating, how this medical neighborhood has come together, not just from the healthcare system, but from the other programs that are involved. I would comment there's been a lot of work done in a number of the communities around childhood obesity. And when you sit down and think about childhood obesity, that's not just even a healthcare system problem. The programs that the communities have begun to think about and work on with the schools, with the lunch programs, with some of the health departments and gyms and stuff in the community, there's actually some fairly innovative programs that are really beyond what you would think of traditional healthcare system disease management programs that have been thought about and are beginning to be leveraged to try to address these chronic diseases in the community. So, when you look at, I guess my point is, when you look at just what's the ratio of what's been hired, I think we would be significantly underestimating, the amount of resources that we're trying to leverage to address these issues.
I'm sure we can all appreciate that too, especially in an environment where a lot of this must be very new to the community as well. One last question I think we have time for, and there were some very specific questions about your baseline data and regarding ER admissions, and I won't put anybody on the spot around what those particular numbers are. I do believe I heard Dr. Ruggie say that hopefully next year he'll be able to talk about the positive outcomes that are coming from the program. And I guess I would just rephrase this question that the person asked more like this. Based on what you know about your baseline data today and the level of ER admissions, do you believe that next year, 1 year into the program, that you will be able to see reductions in those particular utilization measures?
Give us 2 years. We at this point think we know where the proverbial low-hanging fruit are by way of admissions and readmissions and in ER utilization. One starts with the medical home pilot, and we find we need to do new things. So we are expanding our urgent care capacity as a complementary strategy. The medical home is an example. We have dug in bit by bit with our data and realized that 46% of the admissions from nursing homes to hospital require a readmission to the hospital within 30 days. Absolutely unacceptable. And it means not only looking at our own performance, but looking at the performance of the middle-of-the-night nursing staff in the 7 nursing homes where we care for patients. So at this point, we're working on a combination of our anecdotal information, our best intuition, and the bits and pieces of data that are available to us. By the end of this year, we expect to have much more comprehensive data, both from the EMRs and from the claims data, so that we can be systematic in our approach and very thoroughgoing. Based on the experience of other pilots, I think by the end of this year we'll be beginning to make that difference in cutting into costs and showing improvements. But we also know that these workflow changes do take time.
I want to thank you all very much for being so candid with all of us. Thanks to everyone for all the questions. I'm going to turn it back over to Jim.
Yes, and actually I'll be very brief. So this is Jim Crawford again. We ended with a very forward-looking answer, and I'll do that as well. The next CEHIA webinar is in this time slot, March 10th, Thursday at 1 p.m. Our speaker is Jason Karlowish, University of Pennsylvania, who will be speaking on desktop medicine. The regular CPPPI, the Center to Promote Public Payer Implementation, that's third Tuesday at 3 p.m. The next one is March 15th. Thank you to all of our panelists and to all of you who are still on the phone. This has been a tremendous session, and you are inspiring us all. Thank you.
Thank you.